Welcome, my name is Samantha Schwartz. In this video, I will inform you about disparities in pediatric oncology using the Vulnerability Framework Model. For those who were uninsured at diagnosis, the lowest percentage occurred at a localized stage. That being said, uninsured children battling cancer are one of the most vulnerable and underserved groups within the oncology community. Throughout my personal experience as a volunteer on the Pediatric Oncology and Hematology Unit at UF Shands Hospital, I have noticed trends within the population of patients that are receiving treatment, such as those relating to race, ethnicity, gender, and age, all of which happen to be predisposing characteristics of childhood cancer. A risk factor that can be categorized as a need characteristic is outlined by a 2019 Science Daily article that states that acute lymphoblastic leukemia, also known as ALL, is the most common childhood cancer. Children with Down syndrome are 10 to 20 times more likely to develop ALL than children without Down syndrome. A study published by the American Cancer Society in 2017 explains that, given the long-standing concern that current Medicaid coverage does not significantly improve individuals' access to quality cancer care, policymakers should consider ways to improve coverage for Medicaid patients. All children with cancer should be afforded the same quality of care, without taking their insurance status into consideration. In 2017, Cancer Network released the following statistic. Children who were uninsured had a 26% higher risk of cancer death than those who were privately insured at diagnosis. Ample data suggests that children with cancer who receive treatment at a pediatric oncology center have significantly higher survival rates compared to patients treated elsewhere. To date, there are less than 200 hospitals in the United States that have met quality assurance standards established by the National Cancer Institute, receiving the accreditation as a Children's Oncology Group hospital. Not all portions of the United States population have benefited equally from advances against cancer. Cancer disparities exist between childhood cancer and adult cancer, as well as between types of childhood cancers. Children with cancer in 2019 are currently being treated with drugs that were developed in the 1950s, 60s, and 70s. Within the last 20 years, only 3 drugs have been developed and later approved by the FDA to treat childhood cancer, compared to the 185 plus drugs developed and approved by the FDA to treat adult cancers. Between childhood cancers, the 5-year survival rate for ALL is at 90%, while the 5-year survival rate for diffuse intrinsic pontine glioma, or DIPG, is at 0%. Race, ethnicity, gender, language preference, insurance status, socioeconomic status, and geographic location all influence the physical, mental, and social health outcomes of childhood cancer. Racial inequity in health outcomes is evident when analyzing clinical trial study participation between African American children and white children, which is linked to significantly lower survival rates in African American children with acute myeloid leukemia, also known as AML. Children living in areas of high poverty are more likely to relapse early and have a lower overall survival. The factors that contribute to U.S. cancer health disparities include access to and use of healthcare, genetics, physical and mental health, treatments received, social and economic status, cultural beliefs, clinical trial participation, and health literacy. Thank you for watching this video, and hopefully now you'll be able to answer the following 2 discussion questions. The first, how would you prioritize decreasing the disparities in childhood cancer? And the second, propose a strategy for action from one of the 5 tiers of the health impact pyramid. Which level did you choose? Predict the outcome of your strategy.